This is the acute burns management. I will not go through each and everything. This classification based on the source, sometimes very important, where you have to classify it may be a thermal burn, maybe electrical burn. Electrical is again divided into low tension, high tension, and even lightning, and chemical burns and radiation burns. These are the four common sources of burns. And pathophysiology of burns, there is an inflammatory response both at local and distant site, and it occurs in two phases: burn shock or head phase, or hypermetabolic or flow phase. And this description was done by Betson in 1942. And this is the flow chart how a burn affects and produces the burn shock. One aspect is the inflammatory aspect, where the lot of cytokines, histamine, bradykinin, serotonin are all released, which produce what is called the cellular shock. Another thing is the microvascular change, increased vascular permeability, leading to increased extracellular fluid, decrease in intravascular volume, lot of edema, and the systemic vascular response also producing the microvascular changes. So patient loses volume inside his own body, unlike a trauma case where the overt or external breathing is happening. Patient loses the body fluid within his own tissue compartment. So hemodynamic cases causes hypovolemia and burn shock occurs. And during the F phase, these are all the changes. Usually, it is only about the first 48 hours is the F phase. After that, you go to the hypermetabolic or flow phase, where body tries to restore the normalcy. Every system, almost all the systems like cardiovascular, respiratory, planktonic, systemic inflammatory response, hypermetabolic phase, everything is affected. And kidney is very, very important. The usual cause of death in major burns is one is septicemia. Commonest cause is septicemia because the wounds get infected very, very easily, lacking the normal immunological cover of the skin. The second thing is the cardiovascular depression and vascular, hypovolemia, which ensues and produces a renal failure. So these are the two important causes of death in major burns. And a definition of major burn is another common question. So it may be full thickness burn of more than 10% body surface area, or partial thickness of more than 20% in extremes of ages, or 23% in adults, or burns involving these areas: face, hands, feet, genitalia, perineum, major joints, and inhalational injuries to the respiratory tract, or chemical burns, electrical burns, or burn injuries with coexisting medical diseases like diabetes or hypertension, and the burns associated with trauma. So all these things are classified as major burn. So in these types of injuries, even if the extent is very small, it has to be classified only as a major burn. And the role of anesthetist can be anywhere from initial resuscitation to the until the patient gets discharged and coming back again for a post burn contracture release. So you will be involved in this patient right from the time of occurrence of the burn to complete cure of the burn with the subsequent surgeries for releasing contractures and other things. So initial assessment, of course, all of you know, ABC survey, airway management, fluid resuscitation, pain relief is also another important thing, and antibiotic and wound cover, of course, this is the domain of the surgeon, and monitoring. So depth of the burn, of course, it is by the first degree, second degree, third degree, and fourth degree. So degree wise, you can say 4 degrees. And the second degree is actually divided into superficial second and deep second, and full thickness, and fourth degree involves fascia, muscles, bones. So the more and more deeper it becomes a higher grade. And this is a picture to show the various layers of the skin, epidermis and dermis and subcutaneous tissue, and how each part is getting affected in these things. And how do you calculate that? These are some of the clinical pictures of how they will look like the superficial burn, which is very just reddishness. Then there will be blebs in uh, wet burns. So this picture shows the three layers of how the pathology occurs. There is a zone of coagulation where there is a direct tissue injury, surrounded by a zone of stasis where there is a chance that this tissue may survive or become necrotic. Third, there is a zone of hyperepidemia which is trying to heal the second zone. So these three zones are always there in most of the burn tissues. And our aim is to remove the necrotic or the already dead tissue and improve the or make this second zone survive as much as possible so that you can get away or reduce the degree of scarring and the fibrosis formation. So these are all assessing the depth of burns, and this three zones. The description is by Jackson. It is called the Jackson burn wound model. These are all the clinical pictures. This is the full thickness, completely charred tissue. This is partial thickness. This is superficial with the bleb. This is much more superficial, just a reddish line. So you can assess the extent using the Wallace rule of line, and in a little older child, not for the infant, you can use this modified formula. And lung Browder burn diagram is there. So in most of the burns unit, they already have all these things, and you can just shade those areas to calculate that. And Mercer Burns app is the one which was formulated by this. So this is how that drawing of a person will be there. You have to just shade these areas. Immediately it will tell you what is the percentage, and also will give you how much fluid you have to give, calculate the whole thing. So this is two examples of how it is being done. And respiratory burns is another common thing. Supposing inhalation injury is there, how you will see, you can see the larynx trachea up to lower down, it can irritate and produce. So the effect will be laryngeal obstruction, bronchospasm, mucosal sloughing, atelectasis, pneumonia, pulmonary edema, and alveolar capillary defect. So so always the respiratory burns is divided into above the larynx and below the larynx. So above the larynx, we have a direct injury to nose, mouth, tongue, palate, etc. And the upper airway edema occurs within the first 24 hours and then starts subsiding only after a first week. So you have to, that is the reason why if you find airway edema, you have to intubate the patient as quickly as possible. And below the larynx, you get a steam which causes loss of respiratory epithelium and form cast, and there will be a lot of edema at the entrance. And sometimes in a major fire accident in a building, you have to look for other injuries like carbon monoxide poisoning, cyanide poisoning, mechanical block of the rib movement because of the large full thickness burn, and patients may need mechanical ventilation at the earliest. And the airway management, initial burns, you have to prop up the position, patient 30 to 90 degrees. You have to give high flow humidified oxygen, bronchodilator, and you may have to use a fiber optic bronchoscope also. Or sometimes we can go for this LMAs, and you have to use the modern uh, intubating aids with this Fuller scope and video scope. All these things will be very helpful. And fluid replacement, the modified Brooks formula is only 2 ml per kg. Some books say 1.5 ml per kg, whereas Parkland is 4 ml per kg per percentage of burn. So a 70 kg person with a 50% burns, modified you calculate by 2 ml, it comes to 7,000. You divide that into two halves. The first half to be given in 8 hours. So that is 3,500. This divided by 8 gives you 438 ml per hour. Whereas in the Parkland, it becomes 14,000, so almost double. And you have to give 7,000 in the first 8 hours. So that divided 7,000 divided by 8 comes to 8,875 ml per hour. And one simple method is to calculate by what is called the rule of 10, where the body weight multiplied by 10, you have can give 50 ml per hour, 500 ml per hour for 50 kg person. So why do we use lactated ringer? It is first of all, it has been recommended by British Burns Association for a long time, and its composition and osmolality resemble the normal physiological fluid. Contains lactate which may buffer metabolic acidosis in the early post-burn phase. Whereas plasma light has a physiological concentration of sodium and chloride ions which maintain water and electrolyte balance within the extravascular and interstitial and intercellular phase. So there is no fear of hyperchloremia or hypernatremia. And plasma light does not contain lactate and therefore does not carry the risk of hyperlactatemia seen in infusion of large volumes of sugar lactate. It is also calcium free for compatibility with blood transfusion. And where there is a low magnesium concentration occurring following surgery, magnesium from plasma light may help balance magnesium levels also. So this is the picture of the plasma light solution, and you can see this plasma light 148 pH 7.4. Can you say why it is called 148? Plasma light 148. Any idea? So think over it and tell me before we enter the okay. And so parameters to assess the efficacy of fluid resuscitation. You have to get a good urine output. Blood pressure should be maintained. Heart rate should be kept within normal range. CEP, blood urea creatinine, all these things should be maintained well. So if you are using Parkland formula, then you can see check hourly urine output. This is the guide for us for all of us. So based on the urine output, you have to alter your fluid. You can give fluid channel, continue the current fluid rate, reduce. If the fluid is more than one, urine output is more than 1 to 2 ml per kg, you can reduce by 10%. If it is more than 2, you can reduce by 25%. So it is not blindly keep on giving all the fluids that you have calculated. So you have to be very watchful in this also. And factors involved in the outcome, of course, we will not go into that. Pain management is another important thing that may be asked in the exam. So these are all the various drugs that are being described. In a patient who is in acute burn, who is on a ventilator, you can use midazolam infusion, dexmed infusion, antipsychotics. And you can use morphine for background pain and any procedural anxiety, you can use this. And for patients who are not being ventilated, dexmed is supposed to be the first choice, and morphine and lorazepam are all the other drugs. And chronic acute burns, patients who are with pain and who are suffering from burns for a long time, you can go for antipsychotic drugs because it's mostly psychological and they may sometimes get addicted to the drugs also. And for acute burns, this is KPM cocktail, vitamin, tramadol, and midazolam cocktail, with that is 2 ml of ketamine, which is 100 milligram, tramadol 2 ml 100 milligram, midazolam 1 ml ampule containing 5 milligram. So total is for 5 ml is mixed with 45 ml of saline, and you can use an infusion pump and give it at the rate of 1 to 2 ml per hour, which gives a very good pain relief. And you can increase the infusion If you want to do a procedure like dressing change or central line, all these things can be achieved by giving this little larger doses. Why it is difficult to manage the pain in burns patient is there are three reasons. One, there is a background pain, there is a breakthrough pain, and there is a procedural pain. So all these things have to be taken care of. So you have to give adequate pain relief. Other causes are the patient may develop hyperalgesia, allodynia, and opioid-induced hyperalgesia, and also uh, psychological depression. All these things add up to the difficulty in the management of pain. And inflammatory changes, what happens, all these things is just injury to the airway and immune response system, histology. These are all various systems, how they are assessed and changed. Specific criteria for diagnosis of sepsis, which is very, very important. Temperature more than 39 or less than 36, heart rate more than 110, ventilatory, that is respiratory rate more than 25, and thrombocytopenia, hyperglycemia, and intolerance to enteral heat. All these things are indicator of sepsis, so it has to be treated very, very aggressively. The effects on the renal and gastrointestinal system, it can produce what is called the Curling's ulcer or stress ulcers, acute gastric dilatation, paralytic ileus, and abdominal compartment syndrome, acute pancreatitis, and the acute acalculous cholecystitis are all the gastrointestinal effects which we have to look for. And vascular access, you have to have two large IV lines. And, Plus two, for rapid initiation of fluid, you require large IV line. So depending upon the sites, you have to choose whether you can go for a neck line or a femoral line. And hence the challenges are fasciatomy, where you have to give anesthesia at the acute burn phase, the third day or fourth day, or even as early as 48 hours. And when you want to give inhalation induction as preferred, succinylcholine can be used within the first 24 hours. After that, do not use that because of the risk of hyperkalemia. And these are all the various types of scars that you will see after the healing occurs. And this is the X-ray neck to show the maxillophryngeal angle. You can see this is a lateral view of a normal neck with a normal maxillophryngeal 101 degrees. So this line goes parallel to the heart palate, and this line goes through the body of the first and second cervical vertebra. This is the pharyngeal line, this is the maxillary line. Whereas in a patient with a fixed flexion deformity, you see the maxillary line is here and pharyngeal line is here, and the angle is less than 90, 89 degrees. So line parallel to the heart palate is known as maxillary axis. Line passing through the anterior portion of the first and second cervical is known as the pharyngeal axis. So these are all what are the examples of linear scar, mild, moderate, and severe. And these are all band scars, thicker ones, again mild, moderate, and severe. And this is broad scar, again mild, moderate, and severe variety. And by giving IV ketamine, you must be able to hold the mask and ventilate the patient. Surgeon can release the contracture to facilitate intubation, and you can see tube has been passed here. So in a fixed flexion, with the cooperation of the surgeon, can always do this, release the thing. And this is a case scenario I just happened to read yesterday in one article. The patient was scheduled for a neck circumoral contracture release procedure. Laryngeal mask airway, conventional laryngoscopy, and bronchoscopy were ruled out due to the placement of the scar and the proposed surgery in this patient. As a result, nasal route was chosen for performing awake fiber optic intubation. This is the gold standard treatment. The patient was counseled about the intubation procedure in detail with all the risks involved before obtaining due consent for the same. A 22 gauge infrared IV cannula secured in the right foot because both the upper limbs were also having contractures. The patient was nebulized with lignocaine 4% 45 minutes prior to the surgery to anesthetize the upper airway with as minimal discomfort as possible. A femoral central line was secured in the patient after shifting to the OT because both upper limbs had contracture. The standard monitoring with the ECG, blood pressure, and capnograph oxygen saturation started. Surgeon was cautioned for a possible emergency tracheostomy if needed. The upper airway was anesthetized by instilling 1% lignocaine gel in the more patent right nostril before introducing a nasal airway in the same. Now, continuing with that, the induction was started by pre-medicating the patient with intravenous glycopyrrolate, followed by pre-oxygenating for 4 minutes with oxygen flow at 6 liters per minute with a face mask kept closely over the mouth. Now, can you find some contradiction in this pre-oxygenation technique? Something which they need not have done this instead. If you see the last line in the previous one, they say there is a they plan to use the right nostril. So here they say they kept a flexible fibroscope was introduced after removal of the nasal airway. So already they have put in a nasal airway. So the pre-oxygenation could have been done connecting the circuit to the nasal airway itself instead of keeping the face mask closely over the mouth. So this would have been a better way to pre-oxygenate the patient. And they tried to uh, intubate the patient. Efforts were in vain. The inadequate depth of local anesthesia made the patient non-compliant upon introduction of the scope. So fiber optic scope itself could not be successful. And after 3 unsuccessful attempts at intubating the patient, the release of labial commissures were planned as an emergency procedure after integration of 2% lignocaine with adrenaline as local anesthetic agent, following which mouth opening was assessed again and found appropriate for the insertion of I-gel size 3. So intravenous midazolam 1 milligram followed by 30 milligram ketamine and 30 milligram propofol were administered over 5 minutes in small doses while spontaneous respiration was ensured. Following intravenous induction, the plane of anesthesia was deepened by administering oxygen, nitrous oxide, and sevoflurane via I-gel to spontaneously breathing patients. So they have introduced the I-gel. The intraoperative period was uneventful and I-gel was removed when the patient was awake and breathing spontaneously. The patient was shifted to the surgical ICU for post-operative monitoring. So that was the method they did for releasing the contracture. So what we have to learn here is even sometimes fiber optic scope can be unsuccessful. So in that situation, if you are able to mask ventilate and preserve the spontaneous ventilation, then just release adequately just for an introduction of a supraglottic airway, and through the supraglottic airway, you can maintain anesthesia and finish off the procedure. So that is the lesson that you have to learn from that article that they have published. And they have accepted gracefully that they could not intubate even after 3 attempts and are very frank to it. So that is what I just wanted to share with you. Any questions? Any doubts?